Hello, everyone. Welcome to the final session of the HIMSS17 User Experience Forum, demanding a delightful care experience for the patient. I'm Karen Clark, Chief Information Officer for Ortho Tennessee, and a member of the HIMSS HIT User Experience Committee. I'll be acting as a moderator for this session. During our closing panel, we will appraise the impact patient satisfaction has on a value-based care reimbursement model. We will describe tactics healthcare organizations from a variety of care settings use to provide a great patient user experience. Finally, we will identify how healthcare organizations can immediately begin to improve their patient user experience. Here are some statistics that speak to why user experience is so important for healthcare to get right. We're excited to bring you two thought leaders in patient experience to share their insights with you today. Lynn Charbonneau, MBA, CPXP, is a coach at the HealthStream Engagement Institute. Lynn has 40 years of healthcare experience with 25 years in patient experience improvement at Yale New Haven Health, Waterbury Hospital, and most recently at Northside Hospital, part of HCA's West Florida division. Samir Batra, founder and CEO of BAHA Enterprises and a member of the Advisory Board and Resource Advisory Council for the Barrel Institute, is also with us today. Samir serves as a board member on the HIMSS Northern California chapter and is the co-chair of the 2017 ePatient Summit. Please join me in welcoming Lynn Charbonneau and Samir Batra. We have three areas we're going to discuss today. What is the relationship between patient experience and patient engagement? How do patients' user experience impact their care quality and patient safety? And finally, is healthcare a consumer-focused industry? If you have any questions on those themes, or you would like to ask the panelists anything, please be ready with your question at the audience microphones available in the aisles. So let's get started. Our first question centers around the relationship between patient experience and patient engagement. So tell me, are patient experience and patient engagement the same thing?
So I'll start. I want you all, I'm going a little off script. What I'd like you all to do is close your eyes. Just close your eyes, and you know this is the honor system. And we are right in the midst of Orlando. And all in Orlando is the theme parks. So picture yourself on that ride that climbs and climbs and climbs and gets to the top, and down you go. Think about those emotions that you feel during that. That's the patient experience. You can all open your eyes. But what did you feel from an emotional perspective? We heard about it. Dr. Mike started our day today with that, about fear and joy and sadness and disgust, right? All of those emotions play into a patient experience every day. I bring that to you because I think that's one thing you'll remember when you leave here today, is what is that emotional roller coaster that a patient goes through all the time. I'm going to let Samir talk about engagement because he's an expert in that. But go ahead. I'll let you talk.
No, and I appreciate that. And I think it's true. I hear this a lot where people mix both the terms, experience and engagement. So to build on what Lynn said, Barrel Institute actually has a really good definition of it. But it's really the sum of all interactions that you're going to have as a patient across the continuum of care. Right? So it's how I feel, like you said, and all the things that kind of happen to me. Engagement is really what I call the gap between your visits or your touch points with your care providers. So it's all the things that I go through or I do after I've gone to the hospital, or before I've gone to the hospital, or during the process of getting into the next step. But even engagement has kind of crossed over now, and now we're utilizing engagement tools even while the patient or the care team is at the hospital setting. So fundamentally, you could have a patient who has an amazing patient experience, but is not engaged in their care, right? And also the other way, right? I could have a really bad patient experience, but be really involved in my engagement.
Terrific. One of the questions I've always wondered about, from your perspective, where does the patient experience start, but maybe more importantly, where does it end?
So the patient experience is a journey. It doesn't ever end. It actually starts from the time you are born. That's where it starts, because it might start with your mom, right? That's where her experience begins when you are born. And all throughout your life, the patient experience is very prevalent. In this day and age, healthcare is big. We spend a lot of time and effort going through our experiences as a patient. Be one. If you have never been a patient, try it out. See what it feels like. It's very different if you've not ever done it. I was listening to a session this morning, and I heard, and no disrespect to that group, but I heard people talk about that when you create, whether it's a platform for a patient, get the researchers involved. I don't disagree with that, but I believe get the patient involved. Yeah. Ask your patients, what does it look like? How do they really, can they use a platform? I talked with others today about that. If the patient doesn't use your platform, it isn't going to be beneficial to them. So it is a long journey, and things change. Actually, Samir and I talked before this session, and what he said was really revolutionary. If I listened to Dr. Boise before this session, and she talked about the fact that people today, they did a study at the Cleveland Clinic, that people today between the ages of 45 and 70 were much more engaged than those that are either below 45 or over 70. And Samir commented to me, and it was, I'll remember it always, he said that, yeah, but Lynn, think about the 70-year-olds, they started with the internet 30 years ago, 20 years ago. He's right. So it's a very long journey, and it's different for everyone.
Yeah, and I think to me, the other thing is, once you have a healthcare experience, you're a patient for life. Let's just be honest, right? So just even the one time that you've visited a doctor or whatever it may be, you're part of the patient experience. So I think it really doesn't end. And what really, how I really understood that was, I was at a conference for retail. It was a retail conference. And we had somebody talk about healthcare there. And this person got up on stage and he said, you guys in healthcare, and he was really talking to hospitals, and this is a little time ago. He said, you're the only industry that says goodbye to your customers. And I sat there and I said, you know what? This guy's right. Because we're just like, get out the door, go, don't come back.
Right.
And it's funny because now it's changed, right? Now it's all about, oh my God, we need to follow up. I need to engage them. I need to keep them around. Because we've understood now that, if I care for my patient, if I'm involved with the patient, it's better for me. It's better for the patient. So it's really funny to me because value-based care, it has brought that out. And I'm sorry for all the physicians in the room, but you took the Hippocratic Oath that said, you will treat patients and make them better. But somewhere that got lost when it was all about volume, baby, more x-rays, more time I see you, more time you come back, more money I make. So value-based care to me is so funny. It's like, oh wait, you're gonna actually pay me for making people better? Isn't that what I got into medicine in the first place to do? So somewhere for decades we lost it, and now we're kind of coming back to it and saying, wow, what a novel concept. So.
Well, that's a great lead-in for my next question. As we talk about patient engagement and patient experience, the other thing we're all very concerned about and certainly surveyed on is patient satisfaction. So how does that feed into what you just discussed?
So I've been doing measurement and patient satisfaction since, well, I won't say when, it's been a really long time. And long before CAPS and CG CAPS now and CAPS even came into play, or value-based purchasing and all of that. So we always did it a long time ago because we took the information and hopefully learned from it. I mean, that was the purpose of patient satisfaction. CAPS came into play. Many of us in my world, the patient experience world, we were a little offended by the survey. We didn't like it. We said, oh no, you know, this is terrible for us, until we all experienced it, right? And we found that what the best part of CAPS was the ability to move from a how often to, from a how well to how often. And that made a huge difference because patients need consistency in care. And so patient satisfaction, it's an old term, we don't use it anymore, really. We don't call it patient satisfaction anymore. It's really improvement, right? So you take a look at your numbers, right, but it's not about the numbers, really. It's really about how well are you doing? How often do you treat the patients the same, regardless of why they're there? And so I like it. I'm a little bit of a data nerd. I like to call myself that. People say, really? You're in patient experience? I really use the data for a lot of reasons. It just speaks to me, fortunately, and it tells me where are those opportunities to make change. So I find, and Samira and I talk about this often, is that, you know, when you talk about engagement, I believe too, even though it's not always about the experience, but I do believe patients who have a great experience do become more engaged in their care. I do believe that because it's trust. Right? That's where it stems from. Patient satisfaction is trust. Experience is trust. It starts there. And when patients have trust with their providers, regardless of whether it's a physician or their facility, wherever it is they go, that's when you have that patient satisfaction improves, your CAP scores go up, your reimbursement is there, all of those things. But that's not really what it's about. It's really about that patient having a great experience in any facility.
So we should stop using that term. Okay?
Passion, yeah.
Yeah, and you know, it's, I mean, all the measurements that we're talking about, and I call it, when I present on this, I call it measurement overload. It's just like, what's the flavor from the government now? Like, you know, what are we going to measure now? And it's the same thing, it's just we're spinning it a different way, right? So if you look at value-based care, like 30% comes from the domain of patient experience, another 30 comes from quality, and the rest comes from efficiency and process. So, I mean, and you can argue that, you know, those impact outcomes and they impact, you know, process and efficiency as well. So, I mean, it's definitely directly tied to it.
Well, I agree with you completely. You know, in orthopedics, one of the quality measures for us is a functional status assessment after a total joint replacement. We do our functional status assessments via email with a technology that our patients love. We have a 98% completion rate. They tell us they love it. It's great. They're engaged. But we can't count that as a quality measure because it has, CMS says it has to be counted as a face-to-face encounter. So the one we do via email, the way our patients prefer to do it, can't be counted. So I think there's a real lack of alignment between some of those measures and what we're really trying to do with patients. Well, let's move on here to how patient user experience impacts care quality and patient safety, speaking of functional status assessments. So in your opinion, how does the patient experience impact outcomes?
I go back to, and there might be a little bit of a fundamental difference between us, but I do believe that the patient's experience does have an absolute effect on their outcome because, again, if they trust their providers, they typically will follow what their providers ask them to do. And just even if they didn't, that's not a compliance thing so much, but they will typically have better outcomes because they're doing what they're being asked to do. Interestingly, I was on the shuttle yesterday and I had a conversation with a gentleman who talked about his dad, who actually, and I like stories because I think people remember them, but he talked about his dad being diagnosed with diabetes. And his father, he smoked his whole life, he ate whatever he wanted, You know, and they were worried, clearly. The family was worried about what was going to happen. Was he going to follow through? They didn't really think he would. But he talked about this, it was kind of I guess, an electronic thing. Excuse me, I'm not an IT person. But they put it in his house, and it would remind him in the morning, you need to take your vitals, make sure you do your stick and get your blood sugar, see where you are. And he actually lost 10 pounds, did better, right? He was following it because he called his son, who's in your world, most of you, the IT&S world, and called him up and said, hey, you know that thing? Well, it talks to me every day. And he got very excited about it. And I said to him, well, gee, can you tell me, did your dad, did he quit smoking or did he change his diet? He said, oh, no, he didn't do any of those things. But the point I'm trying to make is that he still had a better outcome, right? Even though he may not have been completely where the doctor would have said to him, you need to give up smoking, you need to change your diet. But he did have a better outcome because he lost 10 pounds, so it's great. You know, so I think it does absolutely have an impact on their outcomes.
Yeah, and I think based on, you talked about it, where you said, look, patient experience is really focused on trust, right? So, you know, simple example, let's just say I'm in a hospital and I broke a hip or whatever it is, right? And my experience with my care team is so exceptional, right? They're listening, they're hearing, you know, all my senses are engaged in that sense, right? So, and I feel like I'm being heard. Because at the end of the day, guys, patients, all they want, they just want somebody to listen to them. That's really what it is. And so now you walk in and you say, and you go back to your clinical team and you say, this person is severely high risk for falls, right? And so now that you've built that trust and you walk into that patient and you say, listen, don't get out of that bed. I'll kick your butt, you know, whatever. But I can guarantee you that they'll probably listen to you because they felt like you've connected with them, right? You've built that trust. You care. You know their kids' names, whatever it is. You know all these things about them. So, and that's just a qualitative, it's a story, but the numbers dictated it as well. I mean, because a lot of solutions that, from a technology perspective, that we're putting into hospitals, from a patient experience perspective, they all have a clinical relevance to it. Or even if you put a patient safety solution in, there's a patient experience element to it. So it's all about how I really almost see patient experience as the top, and quality, safety, all these different metrics are really part of that. So, because, you know, at the end of the day, a patient knows if you're being nice to them and you're being mean to them, or if you're listening and not listening. They can't really assess the quality of care and safety and all those other things. Most laymen cannot, but they can tell the experience. And that really ties to, you know, being a consumer, right? So it's the same thing.
We find also that when the patient feels he or she has a very strong relationship with his physician, he tends to be more compliant with post-surgical therapy, more readily set to call us and tell us if there's a problem. So it does build a relationship. Thank you. So the same question then revolving around patient safety. Does getting the patients involved in their own care part of this patient experience continuum, do you think it improves patient safety?
I would say absolutely. And it's even bigger than just the patient, because now the family come into play, right? So there's a number of things that we've talked about in my world for a really long time. If you think about when a patient is a fall risk, right? Samir talked about patient falls. Typically, what do? Well, we put a band on the patient. Maybe if you are fortunate enough in your hospital to have an electronic system, you know, bells and whistles go off when they stand up. All those things that happen, right? You know, beds are built today now. I mean, I remember the Hill-Rom beds that never had any of those things, but they do now. So if a patient shifts the weight, the alarms are going off, right? Because they're on a fall risk. The families, even if you think about all the things we've done around, and this is why I'm getting to that, the things that when universal precautions came in, right, and patients have some sort of a disease that could, you know, spread, right? What do we say? We say to the families, please don't go in the room without gloves and gowns and all those things, right? And So, but they don't always comply, right? They don't do it. And you know why? I know this because we've talked about it for a really long time. We never took the time to explain it to them. This is why you have to do this. It's not just for your safety, it's for your family member's safety. It's for the safety of everyone in this hospital. If you don't do the right thing and you come out of the room and you walk down and, you know, I was reading an article recently, don't even think about the germs on your cell phone screen, right? Anything you touch, right? That's why people walk around there like Purell to death, right? Everybody's got it, everybody carries it. But it was amazing to me because it's stuff we don't even think about. We don't even think that, oh, you know, I'm touching that door handle. I'm sure every time we walk out one of these doors, now somebody's coming by with a wipe.
You mean germs are not like the Metamucil commercial or like that? They're
Right,
like little
yeah, the
green
ones
guys.
that dance around, the little green guys, right? Hachu, and they all dance around, right? So, you know, I think it is a safety issue for sure, and it's really again, using engagement as the term is how do we get the families as involved in the care as the patient? But it's a conversation, it's communication, and I think we sometimes don't necessarily think about that. We just kind of say, you have to do it. Well, we're all independent, right? We don't necessarily do it.
Well, you know, it's a really good point, taking your fall risk example, that when we talk with patient experience, it really includes their family. I know that when my husband had his hip replaced and he was home and I was taking care of him, I was certainly part of that care experience. He was a non-compliant patient, I'll just put it that way. But I do think it extends, the education extends, so you talk about the fall risk, the patient experience, and now it's time to discharge that patient, and now you can say to the family, when you go home, do you have any area rugs? You should tape down the edges. Do you have any small pets that could run underfoot? Do you have any stairs that have wobbly banisters or don't have a banister? And to explain to the patient's family why those things are important, just like the gowns and gloves. To explain that you certainly wouldn't want your mother or father to come back. So it's a great point of view. Samir, do you have anything to say about patient safety?
And I think that just building on that, the fundamental aspect of patient safety is really around communication. So, and if it's communication and patient experience has a big fundamental metric in there called communication as well, it's kind of go hand in hand. So.
Well, let's move on then to taking off Samir's comment, and I love that we're the only industry that says goodbye to its customers. I think
Not
that's,
anymore, though, right?
Yeah,
Not
yes.
anymore.
So let's talk a little bit, is healthcare a consumer-focused industry? I think this is a very timely topic. So really we want to ask ourselves, is healthcare a service industry? Are there applicable analogous service industries that compare to the very intimate relationship we have with our doctors and other healthcare providers? Is there anyone like us?
So I think if you ask people in our world 10 or 15 years ago, I don't think they would say yes to us being a service industry. I remember the days of the doctors saying to a patient, you're going to do this because I said so, right? The I said so time. And it's not like that anymore. I think we've shifted, and truly patients have choices. So they are able to really identify where they want to seek care and from whom. And, I mean, think of health grades, or think of all the reviews, Yelp. Anywhere you go today, you get reviews. I will tell you, I moved to Florida. I live in the Tampa Bay area just over 2 years ago. And it was different. We had been Connecticut people our whole lives. My mother is 87, and she's with me here. And we had to find doctors for her, people that she needed to trust, right? And I will tell you, I knew what insurance she had, so I went out and onto health grades, looked in our area, and found people with lots of reviews that had more than 4 stars, and those are the people I called for her. And I will tell you, it's interesting because like some of the first folks I called and set her up, we didn't go back. We did not go back. That was the end of that, and I found someone else. And what I found was we were much better, and some of them were actually recommended by her primary. That did not go well for us, but I went back online and I went out looking until I found the perfect match for her. So it is much more service-based, and I don't think it's because clinically they were not good at what they did, but it was definitely about the experience that we had in the doctor's office, whether we would go back to that or not. And so I do believe it is much more, and it goes back to what Samir said. People can rank or comment about the interaction. They can't always, unless you're a healthcare provider, really comment about the quality of care that you receive. That's an expectation. They just believe it to be that you will care for them and it will be correct. But they definitely can talk about the interaction that they have.
Yeah, no, and I mean, by far, I'm very adamant about this, and so you're definitely in the service industry. There's no question about it. And I think it's obviously, like you said, taken a long time. I've been in those rooms as a consultant and have had stuff thrown at me and saying, I'm not in the service industry. This is not a hotel, you know? It's like,
Right.
well, you know what? Why are you building your hospitals like hotels now? So, and I think you are in that industry. And I think it's funny because on the technology side or on the corporate side, no matter what business you're in, we talk about how you should be a service business, no matter what you're selling. If you put customer service first, 99% of the time, those companies are the ones that have the best products. So, I mean, I think it's a page that you can kind of take from outside of healthcare and apply it to healthcare. So, and I think with the technology boom and the focus on information and the me now world we live in, you can't avoid being in the service and being labeled as a service organization.
Well, then let me ask you, and this is a question we'd love to ask the audience too. You know, some of the personality traits that might cause someone to be a brilliant neurosurgeon or a fantastic orthopedic surgeon may not be the same warm and fuzzy personality traits that patients are looking for. So is there anything we can do to help patients be more informed customers when judging the impact of the physician's care on their entire experience, so they're not basing that review solely on the interpersonal interaction? Any ideas there?
Well, I think it goes back to communication, right, and breaking it down. I know when I got into healthcare, and I've been at it a long time, you know, we live a world of acronyms. Right? That's what we do. And we talk to patients that way. I think it's better today than it used to be. But you throw all these terms at, oh, well, you're going to have a CBC, and you're going to have this, and you're going to have that, and the patient's like, okay, what is that? Right? And, you know, patients will not ask. They won't ask because, why do you think they don't ask? They don't ask because they don't want to appear stupid or that they don't know. So they won't say anything, and they'll just kind of go along with it. But in reality, they don't really understand what's going to happen to them or what's going to take place. So in this day and age, I think that people, I think we've gotten better, truly. But I think there's still some work to be done. It's that very basic, you know, we teach physicians, if there's physicians in the rooms. What do we teach? What's the best practice? The best practice is you sit at their eye level, and you speak directly to a patient, and you have a conversation, and you break it down into what they can understand. And you don't say to them, do you understand? Because they're going to tell you yes.
Yeah.
You ask them the repeat back tactics, right? Tell me what I just said. I want to make sure that we cover everything. And if they can't, then for sure they didn't understand what you said. So I think it's really back to basics, what I like to call back to basics, and really just sit down and look at them. Again, I use my mother. She's 87. She was a nurse her whole life. She had a cardiac event at age 62, and as a result of a catheterization, ended up with an aphasic stroke, right? And so it's very difficult for her to maneuver the healthcare system. If she didn't have me to do that for her and help her along the way, she would never say anything. She's of that generation that if the doctor says do it, you do. Mm-hmm. She doesn't ask those questions. And then I have a 52-year-old husband with a traumatic brain injury. So and I have to maneuver for him too, because he's, you know, the Rain Man scenario, it's alive and well in my house. So I have to be that person that really has to be the interpreter for patients. So again, getting to our physicians and our care providers to really bring it down to that level that a patient will understand.
And I think this is where technology can really be helpful. So, I mean, I think for like you said, a physician who's not, doesn't have the quote-unquote people skills, how do they kind of get through? This is where they can hide behind the veil of technology. And I think it's also a team approach, right? I think that physician needs to feel part of an organization and a team. And I think our last presenters were talking about how IT, does rounding on staff. It's the same sort of concept from a physician perspective. So there's a lot of technology, there's a lot of tools out there that are starting to help with that, physician feeling comfortable and them getting their word across, even from a clinical perspective, right? So it's kind of broken down. And I think content or patient education content has come a long way. And I focus a lot of time in this industry because it's not just, how would you like to get a ream of paper? And you talked about that recently. Here's a ream of paper. Go ahead and review this. This is your discharge instructions and your education. And that doesn't really help me anymore, right? So break it down to my level. We live in the bite-sized world of YouTube now. 2 minutes, 3 minutes. If you don't explain it to me, it's gone. Right. So, and I think the physician has an opportunity to guide the patient to the information that they want without having to actually necessarily speak it out loud. So.
That's great. I'll tell you that without naming names, we had a patient portal. We no longer use this vendor that had a 99-page user manual for the patient.
Wow.
And when I complained about the 99-page user manual for the patient, they came back the next year very proud that they had gotten it down to a 10-page user manual for the patient. So I think there's still a disconnect between.
Yeah, exactly.
So here's a really, I've always wondered about this question. What's the ROI on patient satisfaction?
Well, I think there's lots of those, right? Again, and Samir mentioned it earlier, it's how do you bring your patients back, right? That's the world we live in because there are so many choices today. And if I look at the big guns. What do I call the big guns? Okay, you're talking about Hopkins and Cleveland Clinic and, Sharp and MD Anderson and all the big guns, right? And even though they are large and have expanded, or HCA even, I'm in 168 hospitals worldwide, what are the things that bring your patients back? What are those things that they don't choose to go elsewhere for care? Again, I live in the Tampa Bay area, very competitive market if you've ever been in Tampa with all of the different hospitals and providers that are available to you. The one thing I will tell you is that it is that engagement or that experience that brings a patient back to your hospital. Somebody who treated them with kindness and compassion, cared about them as a person is what brings people back. Again, going through new providers in that area, we recently, my mom had a pulmonary event that came up, and we took her to a pulmonary doc. We're not going back. We changed, and part of it is the interaction between her and that provider. So, he lost a customer, and in this day and age with VBP and all of that, you're fighting for those funds, right? It wasn't like years ago where you just got paid, right? It doesn't work like that anymore. So really, you're looking at volumes and keeping your patients with you. So I think that's a huge ROI because if people can go to other places, they'll jump ship if they don't have a great experience. So I do believe that, and they look it up now, right? They have access. They go to CMS's website and they look at, who, not on a provider, but on a facility. If you don't have those 4 stars, I'm not going, right? Because I can go somewhere else.
Well, and something to share with your provider, the physician compare site, which now is coming out, health grades and vitals are already written, are writing the code to share that physician compare site out to their site. So although consumers may not know what physician compare is, they sure know what vitals is.
Yeah.
Do you have any ideas on this?
Yeah, and I think, the way I equate it to it's loyalty, right? So I think it translates into loyalty, and there's obviously fundamental factors from a patient experience perspective that are tied to that. So it's all about, and it goes back to the whole, am I a service organization? Well, yeah, if it's based on customer service, which is based on satisfaction, what you're trying to do is create loyal patients who will kind of stick with you. So, and I think it's being attacked in healthcare with, in different ways. So I think patient experience helps it, obviously, by creating an experience that you're going to want people to actually come back. They don't want to have to come back for an episode, but if they have to. Engagement is also a way for you to communicate your brand, your value, your loyalty, right, when they're not there. So it kind of goes back into that same equation as well. And now I think this is one thing I have to applaud the regulation area. I mean, again, it's, the rules come out, we all complain, and it's, they never get it right the first time we get it. MACRA and MIPS now, right? So now they're saying, okay, look, we did meaningful use, we got everybody electronic, we focused on patient experience, quality, outcomes. Now let's start having the physician start paying attention to that. And there's a huge component on there around patient engagement. So I think it's kind of pulling everybody in now and saying we need to focus on this. And so I know we made that comment before where, is quality tied to patient experience or, and those sort of things. We already know that outcomes are based, from an ROI perspective. Well, did you know 50% of readmissions are preventable? And they're caused by lack of communication. So and it's communication around instructions, information, education, and that's obviously tied to patient experience as well. So.
And communication isn't always just face-to-face.
Yeah.
I mean, again, in our world, with our technology
Most of it's
world,
not face-to-face.
it's not typically face-to-face. There are I recently had a conversation with a group, and I said, one size does not fit all. You can't expect that if this is the way you're heading, that everybody's going to get a text that it's going to work for somebody. Like I said, my mother, right? She's not going to be able to do that. I might get the information. Actually, I do for her, right? Because I'm the person who does. But I think that the communication and how we do it is critical to everything we do. And when the patient has that and feels comfortable, then for sure, that's the biggest win in my mind. It's a win-win all the way around.
Well, we've seen a nice win for our clinicians. Up until now, patient satisfaction surveys felt as though, because they were, something that were forced on us, and that we were forced to do and forced to pay for, and we didn't feel that they measured anything meaningful, and it just felt like a giant waste of everyone's time and money. But now that we are doing functional status outcome surveys with the patient post-total joint replacement and some other cervical spine procedures, I'm now getting some of our clinicians coming back to me and saying, hey, you know what, I saw a patient today for his return visit, and he was going on and on about the survey, and he printed it out, and he brought it with him, and he was very excited. And I think that one of the good things about this is our clinicians are starting to get some positive feedback back from their patients, which is why they went into medicine in the first place. And so hopefully maybe we've turned the corner and stop calling it patient satisfaction, but there is an ROI that's not tied to dollars and cents, but tied to very deep sense of satisfaction.
Right.
Well, I think we've reached the end of the questions we prepared. Do we have any questions from the audience? Is there anything anyone would like to ask our panel?
My name's Bonnie. I'm a family doctor,
hi,
and I'd like to ask for some tips on wait times. That's one thing that really impacts the patient experience. We find that patients save up lots of things. When you come to a primary care provider, anything goes, and we love our patients, and we want to provide a great service. Each person wants lots of time, but nobody wants to wait, so that doesn't work on an every 15-minute schedule very well. So give us some tips. What can we do?
Delays, yes, the second highest after customer experience. So, yeah, I think that you're right. Patients, they demand that time, really with a primary care physician for sure. So I think, again, it goes back to communicating that, right? So when you arrive and it's setting the expectation, I think, is the biggest thing. So making sure that if things are a little bit behind, now I remember the days where you'd sit in a physician's office for an hour waiting. I think we've moved beyond that to, at least my experience, we've moved beyond it. But I think it's telling the patient right up front. I know that we're running a bit behind. Sometimes patients even like to know that and say, well, perhaps you need to run an errand, maybe. Go ahead and do that. You have your spot. We won't pass over you. Go ahead and do that and come back. You have 20 minutes or you have 25 minutes. I think it's really understanding what that means. And you'll know, typically your staff know or you know that how far behind you are running. I think it's also scheduling. That's the other thing. Sometimes I think we try to jam too many patients in. And part of that, I mean, I don't know if it's still the case, but I know that in my life, it was always about no-shows, right? So let's build the schedule because we're going to have no-shows, right? There's a percentage that you can count on of people not coming. And that goes back to that relationship between the provider and the patient, because if you're making those calls the day before or sending a text or an email, whatever it is that you use, we want to remind you have an appointment tomorrow. Sometimes that helps, and I think we're better, as I said, I think we're better today. But I think it's setting that expectation and knowing, because patients are willing to do that. But again, there's the risk. If you say it's going to be 20 minutes and then you're an hour, then you're going to have a very unhappy patient. So you have to really be realistic about it. But I would tell them right up front. Sometimes we avoid it because you don't like the way it feels, right? Because now they get mad. Well, you told me 1 o'clock, and now now you're telling me it's going to be 1:30. So it's really being upfront and honest about it. I think that's really when patients are a little less volatile, if you will, about it.
So I think technology can play a part in this for sure. So I think not simple things, but certain things where you're going to have them come in and fill out things, having them do those before they get there through a mobile solution, through different. So there's definitely technology that's existing there. There's also a technology that exists that is actually fundamentally helping the patient-physician communication cycle, that whole 8 minutes in cloud of dust, as we call it. And it's called smart checklists, smart patient checklists. And off-cycle, I can talk to you about some of those providers. I don't want to, it's not a commercial. But I can definitely talk to you about those off-site.
So I'm very much in agreement with a lot of what's said, but I'm going to challenge you a little bit. So just don't take it as I'm trying to throw everything else out.
Not personal. I get it.
In geriatric medicine and in oncology, there are a lot of conversations that really need to happen that will result in people being angry and people being upset for months, right? And they need to be done with tact and with caring, but at the same time, that's going to leave oftentimes the patient and even more often family members really angry with your experience. And if you take the other side, if you look at a lot of facilities that are not having those difficult conversations, they're making things worse, right? The family members are happier. Sometimes the patients are happier, sometimes not. But they're avoiding that, right? They're avoiding that to get that positive experience, and they're ending up with worse outcomes.
Yeah.
Yes.
And so my one comment is that, just to everyone, is that the experience is not all the be all and end all. Often there is a relationship to outcomes, but it's not the be all and end all. The second part is a question of when you're looking at information on experience, how do you sort out those other pieces so that you are encouraging doctors to have more of the discussions that we need to have? It's something that's really lacking right now. And how do you encourage them to have that while at the same time taking advantage of all the positive trends that we're seeing now in engagement and focusing on the patient?
So I can speak a little bit to that. When I was at HCA, actually, it was one of 16 hospitals in West Florida. And we made a decision. I think 2016 was the year of the physician, believe it or not. And that's what I called it anyway. And we created scorecards based on our patient experience measurement tool. And what we did is, the reason we did that was really not to beat anybody over the head or any of those things. That wasn't the purpose. But the purpose of it was really to sit down with the physician, which is exactly what we did, and explain what this meant. What does this mean? The communication domain in caps, right, on the inpatient side. So we sat with them, and they said, oh, no, when they looked at it, well, this can't possibly be me. And we said, well, this is, if your name's on that record, actually, this is you. Even if you had consultants, you still own it, right? So be choosy about who you pick to cover for you. But we sat down with them, and we did that. And then it brought a whole level of awareness to our physicians that I don't think they really realized. And then we did a rolling 12 months of data, because I don't like quarters because it's not big enough and the N isn't sufficient, so we don't do it that way. And what we found is every single one of the physicians, their scores improved, because sometimes it's just an awareness. Now, going back to what you said about the disease, the chronic disease, or a new disease, or a newly diagnosed, pretty devastating illness, I sometimes when you deliver that message, it's almost like an emergency room physician, right? Someone died in the ED, right? And they come in and no one expects that, and they're sitting in a family room. And now an emergency room physician has to come in and tell them that their 30-year-old son died, right? The same thing happens that you described, that anger and upset and all of the things that play into it, and how could that happen? But I think sometimes you just need to be. You don't talk too much. You say what you need to. You start off with, I'm very sorry. People used to tell us we couldn't say that, but we can now. I'm very sorry to have to tell you this. And you just let them go through the emotions. You're not going to fix it, but you're going to be there. I will be here for you every step of the way. I will make sure that we communicate. I will make sure that I make time for you. And that's when people switch. And you don't try to hide things, because again, when you figure that out later, we just talked about that before we started the session, it's never to your advantage. But sometimes you just need to let it sit. And I know you think that months down the road they're still angry. Probably not. I will tell you, in patient satisfaction, well, they might be angry, but in patient satisfaction world, like if you send out a survey, it's an ED survey or an HCAPS, or you have phone calls or whatever, I will tell you, of the people that respond, everyone says, oh, it's only the unhappy people respond to surveys. That's not true. It's probably less than 3%. So it's a very small window of folks that are unhappy. You will see, for the most part, in the HCAPS using CAP survey, with it being the top rating, is typically above 70% in this day and age. Wasn't 5 years ago, it was much less, but it is today. So I understand what you're saying, but I think that sometimes you just have to let it sit.
Yeah, and I okay.
Sure.
So that makes sense. I think should have been more clear. The thing that's in my head is more where the physician is in a situation where, having to say, I don't think you're a good candidate for surgery. That's not a way to go. You're in a chronic condition. Or,
Yeah.
Maybe we should talk about hospice options or whatever that is.
Yeah.
Where you're actually part of the decision
Yeah.
that they don't like. Like, the emergency room thing is one thing where
Yeah.
something happened and I was witness, but when you're actually part of the thing that they don't like, it becomes harder. And I guess, so, and I get your point. I guess I'm more interested in, from the side of looking at that data, how you're looking at all the physicians getting better. Well, maybe there's one that's way down here, but you realize that, what, they're having a good conversation with people.
Yeah.
Yeah.
And I think so. The one thing I wanted to say on both these points is, and I like when Lynn speaks first, because then I can build on what she's saying. It's kind of cheating, but
We've been colleagues for a long time.
I'll just do it that way. So the one thing on your first point, first of all, I would never send a physician in there by themselves.
Right.
I'm sorry. So, Cleveland Clinic came up with this whole concept called Code Lavender. I don't know if anybody's heard of it. So Code Lavender, right, is like, it's kind of like Code Blue, right? Code Blue happens, what, like 20 people show up in your room. Same thing. Code Lavender is, hey, you know what? We just had a lapse in patient experience. I would apply that same sort of mentality to what you're talking about, right? Look, pardon my French, but that's just going to be a shitty conversation, right? No matter what happens. But I want you to know that it's not just me. Look at it. You know, us as an organization, we're here to support you. And then that lavender code has to continue. Like, you know, data collection. I'm sorry, it sounds kind of, you know, primal. Oh, we're going to data collect on how pissed you are for how long. But you know what? That's a good way to do it, right? So let's collect that data and figure out, well, you know, fundamentally it's 4 to 6 months. It sounds so bad to say it that way, but then you know I'm going to keep checking in. And you know what? It's one of those things where, you know, my kids are really young, but as I'm told, when my kids become teenagers, they're going to tell me they hate me, right? And so am I going to sit there and be like, well, too bad? No, I'm going to keep telling you, hey, I love you. Keep giving me a hug, you know, and even though they're like, yucky, get away from me. It's that same mentality, right? Keep telling them, hey, you know what? I'm here for you. I hate you. I'm here for you. I hate you. I'm here for you.
Right.
And eventually they're going to get past that. So I think it's, I mean, you know, I treat everything in this scenario as how can I analyze it and break it down with data. And I think the other piece that you mentioned, you know, it's so true because I've done that where it's qualitative versus quantitative. You have to have both to tell the story. You can't just do quantitative because that physician, he might have crappy scores, but you know what? He's probably doing the best for being accurate with his patient. So there, you know, there's organizations like Docent Health and other companies that are starting to look at, you know, how do we actually take the conversational elements of the patient experience and look at it and analyze it. So I think that's what I would say is even things like, you know what, this guy's data looks low. Actually, we need to do patient focus groups. Let's go and poll some of these patients and find out what's really happening behind the numbers. And I think that's where you can help not only that patient, but also help that physician and also help that physician from an organizational perspective.
And so I coach for a living, right? That's kind of what I do. And actually, as a result of some of the scorecard stuff, and we had a residency program as well, that's what I did. I actually went out with some of our physicians and rounded on patients with them and gave them feedback, not in the room, of course, but outside of the room. And I will tell you, I said, you know, these are the points you want to hit. Kind of sit down at the bed, you know, those basic stuff. It doesn't go away. That's why it's the best practice forever. So sit down, talk to that patient directly. I hear what you're saying about that difficult conversation. Sometimes people aren't just ready to hear it right then and there, right? You deliver it, they're angry, they're upset. What do you mean hospice? Oh no, we wouldn't even consider that. So that's why I said you kind of have to let it sit and maybe revisit it a little bit after they've kind of digested it. At least that's the experience I've had with physicians, because I've sat in those difficult conversations. They're not easy to have. They're terrible to have. And the families just don't ever expect it. And again, you just have to keep at it in that compassionate way of, I know that you know, let's talk about what are you afraid of? What's the worst thing for you? Let's talk about that. Sometimes that helps because you're tapping into a different emotion for them than what's right in front of them sometimes. So let's talk it through. And I know that's hard because your time is probably this much and it takes this much, right, to be able to get there. But I think that when you do that, it really creates that relationship between you and your patient and their family that you can have those discussions going forward, because sometimes they'll take a step back, most of the time actually. There's always those few that won't. But the ones that step back and say, you know, he was right. We need to look at what's the best thing and how do we get there? And it's between your relationship and them, I think. So it's just that, be there. You just have to let them breathe sometimes.
So quick question on I like the comment of patient for life. Is there a way that you're seeing that actually being exhibited or realized, or maybe even directionally, we're getting a patient for life? There's a lot of surveys out that suggest that patients are willing to dump one primary care for another, and for a small copay, or certainly we've got network challenges with changing insurance or employers or that sort of thing. But I do see and appreciate the value that a patient for life can really exhibit that long-lasting trust, and I can ultimately be seen as a physician. I'm not a physician, but if a physician can be seen as someone other than just simply sick care, but actually achieve like a wellness relationship. So I don't know if you've seen that kind of an example in either one of you.
Well, patients are your best marketing tool, I think. I mean, they really are. I mean, if they have a great relationship, they tell all other folks. So an example, again, I probably have a million of them because I've worked in healthcare for so long. But we moved to Florida, right? My mother picked a primary care doc, really liked her, thought she's great, but then her primary care physician from Connecticut moved back to Florida, to Tampa. She switched. And it wasn't because her first primary care physician wasn't a great physician. She was, and much more local to where we live. But she had that relationship, and when she heard that physician came back to Tampa, because that's where she started, then went up to Connecticut, went to school there, it was in primary care practice for a little while, but moved back home, because it's her home, Tampa area. And we heard about it. She did make that move. And, you know, that is because of the relationship piece, I think. When I said to her, this is what happened, and she said, I want to go to her. So we made the move. But it is all about how do you keep a patient for life. Insurance is a really tough one today because people have insurance, and the insurances do dictate who you can go to or who you're not. I mean, if you're lucky to have a really fabulous plan, not so much. You don't have to have that kind of HMO feel. I know for me, I'm in an HMO, so I have to kind of do it that way. But having had plans where you don't have to, my mother's is one that's broad, so she's fortunate. But that really does come into play because people don't want to pay that big money. And with copays and deductibles now, it's pretty sizable for people. And if you're on a fixed income, it's a little bit of an issue for patients. So.
Yeah. So how the politics of healthcare are impacting that answer are, so I threw out a statistic from a research report that I saw that said there's been a contraction in number of healthcare providers, and people are like, what? I see more hospitals being built. Well, what's really happening is that when hospitals were faced with value-based care and they said, okay, you need to own the entire patient journey, they looked around and they said, crap, I need to go on a spending spree. So they started buying things, right? So that's what's really happening also is that you have, you know, the big guy, there are no little guys anymore, right? I don't know if, you know, I know a handful of people who work at community hospitals and they're just on the process of getting bought out. So, I mean, I think they're starting to own the population from that perspective. And honestly, it's like the ugly word that, you know, I don't want to really talk about, but we're at HIMSS, it's interoperability, right? I mean, it's like we're still struggling with that. And I think the consumer technology angle that's coming out that kind of is creating that separation layer based on SMART and FHIR is going to hopefully help us down that road in terms of creating much more of a, you know, overall picture. And I think that's where some platforms are starting to create scenarios where you can create a virtual care team, right? So what I would challenge to do would be, you know, if I went to System A and they're using Epic, you know, I had my physicians from there, and now I've gone to some other hospital that uses Cerner. Well, yes, the interoperable issue is there, but how, from a virtual care perspective, are you going to connect my physicians? Even if I have to switch, how can they still talk to me? How can they be part of that care team that I have? So patient for life, that team is just going to grow as I get bigger, right? As I get older. It's not going to shrink, but it's somehow those folks need to still be in contact. Health IT is not going to solve that. Epic is not going to solve that. That's going to come from the consumer side. So.
Well, thank you. We've come to the end of the HIMSS17 User Experience Forum. Please be sure to complete the evaluations for this session, and I would ask you to please join me in thanking Lynn and Samir for their participation today. Thank you.